I thank the senator. The question I was going to ask the distinguished senator from Massachusetts.
The senator made a unanimous consent request. It's granted.
Yeah. Thank you. Mr. President.
Senator from Oklahoma.
The question I was going to ask the distinguished senator from Massachusetts is how many Medicare Advantage patients has he ever cared for? How many Medicare patients has he ever cared for? How many times has he been in the trough experiencing the heavy hand of government as we try to care for people on Medicare? The answer to that question is zero, because he's not a physician. He relies on the American Medical Association, the American Medical Association that today represents less than 10% of the active practicing doctors in this country. He relies on AARP, who has 40 million in membership, but is the 5th largest revenue receiver from supplemental policies. That's who he relies on. The fact is he doesn't have the experience of being in the trough caring for patients. Now, let me tell you what's going to happen to Medicare Advantage patients. The senator would not yield to me. I have no intention of yielding to him.
Well, no, I was ready to yield on your time.
The senator would not yield. I will continue my talk. Medicare Advantage patients, there's no question. I've agreed with the chairman of the Finance Committee that competitive bidding needs to happen. But there's one little thing that happened on the way to the bank, is that there's going to be a decrease in benefits. Not only a decrease in what we pay for them, but there's going to be a decrease in benefits. And where will that impact be most importantly felt? Not in the urban areas. It's not going to be felt in the urban areas. It's going to be felt in rural areas throughout this country. That's where it's going to be felt. It's going to be felt out there where there's a marginal rural hospital that is using the other benefits to help maintain the float of that hospital. So there's no question that if you're one of the 11 million, or with the exception of those that got deals cut in this bill, that for sure the 90,000 Oklahomans are going to feel an impact from this cut. Now, nobody says Medicare Advantage is perfect. It's not. It's far from it. But there's another aspect of Medicare Advantage that really helps those on the lower rungs of the economic ladder. Is with Medicare Advantage, they don't have to buy a supplemental policy because all the things they need are covered. 94% of Americans on Medicare purchase a supplemental, that are not on Medicare Advantage, purchase a supplemental policy. Why do they do that? Why do they spend $300 or $400 a month to buy a supplemental policy? Because basic Medicare that we have proudly said will not be cut doesn't cover the basic needs of a senior and their health care. So consequently, they pay into Medicare Part A, HI trust fund, their whole life. They buy Medicare Part B, and then they buy a supplemental policy. And it just so happens one of the largest sellers of those policies happens to be somebody that's endorsing this bill. If that's not a conflict of interest, I don't know what is. I heard the senator talk about Massachusetts. I'd relate an article from the Chicago Tribune. They have broadened care, and I'm proud of them for doing that. But at what cost? At a 10% increase in cost of premiums for the people in the middle. So when we go back to what the president said about what his goals were, there's no question that this bill does not keep those promises. I'd ask unanimous consent now to turn to another area which we have discussed and ask unanimous consent to put into the record an article from the North County Times of the California dated December 5th, 2009 at 9:35 p.m.
It is reserving the right to object.
It is so ordered. Oh, the senator was...
I reserve the right to object. I won't object, but I'd like to just find out if we could have a moment to have a discussion. I'd ask my colleague.
I will offer you the same courtesy you offered me. When I finish my remarks on your time, you're more than welcome to refute what I have said.
I have no objection.
This past week, I asked unanimous consent to enter this into the record.
Without objection, the senator may proceed, and his unanimous consent request is granted, as it was before.
in this bill that we're debating are three terrible things for care, but great things for cost. It's the U.S. Preventative Task Force on Prevention Services. It's the Medicare Advisory Commission, and the references to the Cost Comparative Effectiveness Panel. You know, when the United States Task Force on Preventative Services came out with their recommendation, as far as cost, I'm talking on breast cancer screening for 40 to 49-year-olds, as far as cost, they were absolutely right, as far as cost effectiveness. But as far as clinical effectiveness, they were absolutely wrong. And what did we do? We accepted a Vitter amendment to hold off so that that recommendation, that mandate from that panel won't apply to women in this country under these programs, except the women in California on Medi-Cal. Because you see, this week, California embraced U.S. Preventative Health Services Task Force, so that if you're a Medicaid patient, where we're going to put 15 million more people into, you can't have a mammogram in California if you're under 50. You can't have it, because from a cost standpoint, they're right. From a clinical standpoint, they're wrong. And so what we have done is every time one of these three organizations creates a ruling that the American people rise up and say that's wrong, we're going to come in here and correct it. But throughout this bill, strewn throughout it, is multiple references to what these three panels are going to ration, and I didn't miss that word, ration the care to American people in this country. If you're a senior, you have two real reasons to be worried. One is we are cutting Medicare, and if we're not, then vote for the Gregg Amendment, and you'll make sure we don't. It's an insurance policy. But more importantly, within that, we're going to see the care to seniors rationed, based on not what is in their own best interest or their health's best interest, but is what is in the cost's best interest. There's no question about it. We're going to do that. It would be different if we created a comparative effectiveness panel, a clinical comparative effectiveness. But they're already out there. We knew that. When I studied to take my recertification exams, I have to know what the clinical comparative effectiveness guidelines are, or I won't pass it as a practicing physician. But we didn't do that. We said cost is most important. And so how are we going to cut? We're going to say where something's cost effective, though not clinically effective, and we're going to cut that care out. So if you're a senior, especially if you're on Medicare Advantage, you don't have to just worry about the fact that we're going to decrease the revenue stream that's going to supply those benefits that causes you not to have to buy a supplemental policy, and we're going to decrease some of the things that are available to you as a Medicare Advantage patient. But you also have to worry about what the next ruling that's going to come from the U.S. Preventative Health Services Task Force. You have to worry about what's going to come from the Medicare Advisory Commission, because it's going to be looking at cost too. And then you have to worry about what's going to come from the Cost Comparative Effectiveness Panel. I could spend 8 hours up here talking about tragedies from England and Canada on care denied, based on things Americans have today that very panel is going to deny to Americans in the future, because they're not cost effective. That's one of the reasons that our results in terms of cancer treatment is a third better than anywhere else in the world, is because we don't have mother nanny bureaucracy saying what you can and can't have. It would be totally different than in this bill that if we created incentives for lowering the cost, but we don't. We create mandates. We drive down costs of health care in specific areas through these 3 separate panels. Now, there's even one thing that's even worse than the 2 things that I just talked about for our Medicare patients. And here's what it is. When you have these 3 panels, you have just taken away the loyalty of your physician to you. You have just decided with these 3 panels that the physician has to keep their eye on the government. And they have to do what the government says is in your best health interest, rather than what that provider knows is in your best interest. And remember that the Medicare Advisory Commission, the Cost Comparative Effectiveness Panel, and the Preventative Task Force Panel had never touched you, doesn't know your family history, doesn't know your clinical history, has never done an exam on you, doesn't know the idiosyncrasies of your health care, but we're going to apply that all to you. We're going to depersonalize health care. And I readily admit, for 80% of the people in this country, it's going to be just fine. You're not going to see any untoward result. But I will predict to you as a practicing physician for over 25 years that for that remaining 20%, it's going to be a disaster as far as their personal health is concerned. It will destroy the patient-doctor relationship, number 1. It will give us worse outcomes, and it will not save us any money because the consequences of those decisions will create a complication which will require more dollars expended. When we think that the government can practice medicine, and that's what this bill does. This bill sets the government up to practice medicine. When we think the government can practice medicine, we might as well hang it up and just be ready that 20% of us are going to get far substandard care to what a Medicaid patient sees today. That's what's going to happen. And we're going to get sicker, and I'll repeat it. The life expectancy of people in this country under this health care bill will decline. Will decline. The quality of care will decline. The innovation of new advancements in health care will decline because we have chosen the government to decide what everybody will get. It's a disaster as far as the individual patient is concerned. That's not the motivation of my colleagues on the other side of the aisle. I know that, and I'm not accusing them of that. But what they don't see sitting in Washington is what I see in a clinic office practicing medicine. And that medicine is intensely personal. It ought to be about your choice, about what's best for you and your family and your children, not what the government says makes the best economic sense to the budget picture in Washington any particular year. And when we lose that quality in American medicine, we're going to lose the best of what we have in America in the name of fixing what's wrong. I agree with my colleagues that the insurance industry has a lot of stink to it. But there's a lot of ways to fix it other than the way we've done it. I agree with my colleagues that my profession is not pure at every turn of the corner. I agree with my colleagues that we can do better. But when we write a bill that is absent of any absolute clinical judgment left to the practice of medicine by those who know the patient's best, who have 100% of that patient's best interest at heart, we're going to hurt the quality of care in this country. And we're going to hurt it significantly. Your motivations are good. The answers are wrong on a clinical basis. Now to the Gregg Amendment. The Gregg Amendment does what you all say you want to do. And I would remind my colleagues that the Medicare trustees are highly suspicious of the Medicare cuts in this bill. And what they say is they can claim it, but we highly doubt that it'll ever happen, because it's never happened before. Because there's not the political will to decrease the dollars in Medicare. And more importantly, the dollars are going to come out of care instead of out of fraud. For there's only really $2 billion, say, out of at least $100 billion a year, at least $100 billion a year in fraud, only 2% of it per year is coming out. And you know, that's the problem because this thing was so partisan. We could have had a Medicare bill and we could have cut $60 or $70 billion in fraud together out of this bill. We can come together on that. And we could have cut $720 billion out of expenditure out of Medicare just based on fraud alone, without ever touching Medicare Advantage, without ever giving sweetheart deals to the people in Florida because their senator wanted it, without ever touching FMAP adjustments in other states. We could have done that, but we chose not to do that. And we chose what we know up here rather than what we know out in the hinterlands of those that are practicing medicine. And what do we know? We know there's some rip-offs in home health care. We know there's significant rip-offs in durable medical equipment. We know there's some rip-offs in hospice. We know there's drug company rip-offs. We could agree to some of those. We actually even know in large hospitals that there's some problems there as well. But there's very few problems in our rural hospitals because they're struggling just to keep the doors open. We could have done that. But we chose not to. And so we have this divide, and we're going to fix it one way. And the biggest pot of honey in Medicare is fraud. The biggest pot of honey. Everybody knows that. But we're not going to fix it. The whole purpose of the Gregg Amendment is to prevent us, if in fact what my colleagues claim, that these are Medicare cuts that nobody will ever feel any consequence from, in spite of my own years of practice and knowing the difference that isn't true. But let's give you that. Why would we not put it all back in Medicare? So that we don't steal from our children and our grandchildren. Why would we not do that? We've chosen not to do that. We've chosen to mix it. And we've chosen to create another, and it's honorable to try to create a system to get more people insured. But yet we're still going to have 24 million people in this country not insured. We're still going to have, out of a $2.5 trillion bill, we're still going to have 24 million people in this country not insured when it's all said and done, if everything goes as planned. I would also note that with the Gregg Amendment, as well as with several of the others, yesterday I introduced into the record the analysis by the State Insurance Commission in the state of Oklahoma. Kim Holland is of your party, the majority party. But she sees what's getting ready to happen with this bill. And what does she say? What she says is that insurance premiums are going to significantly rise in Oklahoma. What she says is more people will be uninsured than they are today. What she says is the state Medicaid fund is going to be tremendously stressed with at least $67 million a year having to go into that again based on the mandates in this bill, that we don't have that money to do it. And that in fact, it's not the way to solve the problems that Oklahoma's facing in terms of their health care. She said, I didn't call her and say, give me something bad to say about this bill. She volunteered this information out of her legitimate concern of the consequences of what's going to happen with this bill. Now, why would she do that? because she knows one heck of a lot more about insurance than I do and anybody else in this body. She knows it in our state and the other insurance commissioners around here. Some, through their association, have endorsed this bill. Most, when they look at their state, especially the poorer states, especially West Virginia, it's going to hurt. Now, how are we going to cover that? We're going to shift 15 million people to Medicaid. What do we know about Medicaid? I've delivered thousands of babies, and over half of them have been Medicaid. I've cared for thousands of Medicaid children, thousands of Medicaid adults, and thousands of Medicare patients. What do we know? Medicaid is a substandard program. Compared to everybody else, it's substandard, except when you compare it to Indian Health Service. And that's a disaster. So our answer is to put a mandate on the states that they can't afford and shove another 15 million people into a system that has poorer outcomes, higher complication rates, a higher infant mortality rate, later presentation, and a system that has 11 million people that are eligible for it today that aren't even signed up. We have the system out there, but they're not signed up. So they're not getting any preventative care. They're not interacting with a primary care physician. And that's our answer. Move 15 million more Americans into Medicaid. And by the way, keep a discriminatory stamp on their forehead. Rather than give them an insurance program, put a stamp on their forehead and says 40% of the doctors, by the way, can't see you, 65% of the specialists won't see you. Because your reimbursement rate is so low, they can't afford to have you walk into their office and cover the cost of seeing you. That's what we're going to do. That's not reform to health care. That's banishing people to a substandard system as compared to what the rest of the system is in this country and then feeling good about it. That's not reform. That's discrimination. And it's a discrimination because here's what really happens to a Medicaid mom and her children. Is she's got a sick kid and she can't get in. She's got this sick 2-year-old with a fever, not eating, dehydrated, and she can't get in to see a primary care physician, which could keep that child out of the hospital. So what happens? She keeps trying to get in, and what does she do? She accesses the emergency room, the most expensive place, and she accesses it late. Not early, late. So we have a sicker child with higher costs because we have a system that won't reimburse its cost, and you all have actually talked about the cost shift on that. From Medicare and Medicaid to the private sector. We'd be much better off paying the same rates in Medicaid so we don't get that cost shift, so we don't discriminate against people on Medicaid for access to care. But we've chosen not to do that because it fits with the numbers. It fits with the Washington government-centered management of health care. I will tell you as a physician, we'd be better off single-payer rationing and all than what you're doing to so many of these patients in this bill. We'd be better off with the government just running it all, ration it and say, tough, you get 75 years of age, you can't have your hip fixed. You get cancer, we're not going to give you the latest drugs. We'd be better off because now we're going to get the worst of both worlds. We're going to get the rationing through these 3 panels that I talked about. They're going to tell doctors what they can and cannot do. They're going to practice medicine. The very people who've never touched, never had an encounter, never visited with that patient, don't know anything about, they're going to make a decision. I would inquire, I think I have 5 minutes left.
Senator is correct.
What is the request of my chairman?
Senator.
I would just respond that I think that Senator Coleman, you should use the balance of the time, and then I'll be able to work. The Democrats have a few minutes left.
I think I'll finish up here in just a second.
Well, you take the balance of the time if you like, and then it'll be my opportunity in a few minutes.
Every person in this country should be able to have access. I agree. Nobody should lose their home. Nobody should have to file bankruptcy because of health care. I agree. That premise we agree on. How we get there are two totally different ways. The number one impediment to access is cost. Costs aren't going to go down in this bill. We know that by all the studies. The health care costs are not going to go down on this bill. They're not going to go down per individual, and they're not going to go down in total. So we will have not fixed the big problem with health care, which is cost. We will have worked on access through government programs, but we will have not fixed the real problem. What are the real problems? Fraud. At least 6% of cost of health care. Toward extortion by the trial bar, at least 6% of the cost of health care when you count defensive medicine. There's 12%, you could lower it tomorrow. 12% you could lower the cost of health care tomorrow. If in fact we would fix the real things. Number 3, transparency with insurance companies and transparency with doctors. So you know what the cost is, you know what the outcomes are, you know what their track record is so that you can truly make a decision about your care. There's no incentive in there for that. The incentivization for prevention and management of chronic disease. I've said this on the floor before, but it bears repeating. The reason we have a primary care doctor shortage in this country today is because of Medicare. The Center for Medicare and Medicaid Services sets the rates of reimbursement for primary care encounters in Medicare, and everybody else follows it. And so you have a disruption, a differential of 300% from a family practice doctor, an obstetrician like me, to a super subspecialist. And what do you think the doctors in medical schools are doing? Only 1 in 50 last year went into primary care. Only 1 in 50 went into primary care. So let's say we get everybody covered. Who are they going to see? Oh, I know what the answer is. We're going to use physician extenders. So not only are we going to say you're covered, now we're not going to give you the experienced gray hair, reasoned, long-term, educated balance of having a physician whom she might have had 25 or 30 years of experience. We're going to hand you off to somebody that's a nurse or a PA who are good at limited things, but don't practice the art of medicine. So I'll wind up with this, Mr. President. I so want to fix health care. I'm so sick of the way it is. But I'm not near as sick of the way it is as the way it's getting ready to be under this bill. I know my patients are going to get hurt under this bill. My Medicaid patients are going to get hurt under this bill. My Medicare patients are going to get hurt under this bill. And those that are in between, whether with insurance with their employer or insurance that they're buying on their own or they're paying cash, are going to pay more for their health care because of this bill. Now that's what I believe is going to be the outcome of this bill. And all you have to do is go look at the history. Talk to Alice Rivlin, the first CBO director, about the accuracy of CBO in estimating anything when it comes to health care. They've missed it every way. They've only got one wrong by saying it was going to cost more. Every other one, they said it's going to cost less than what it did. So every patient in some way or another is going to suffer under this bill. That's what we should be worried about. We shouldn't worry about whether the president wins or we win.
Senator's time has expired.
I thank the president for the accommodation of the time, and I would yield the floor.